There are no relevant financial disclosures for me to make. I think it's good for us to start with the definition of an exposure in pregnancy that is harmful. That's my definition of a human teratogen or teratogen. It's not just producing malformations. It's really could be any of several fetal effects. There are lots of different types of exposures in pregnancy that could be harmful to the fetus. I've listed here on this slide the several different types with a couple of examples of each. Most pediatricians are well aware of intrauterine infections. They're well aware of medications the mother takes as risk factors. Probably the most common situations that you might see or learn about when you're seeing a newborn infant would be when the mother has insulin-dependent diabetes or that she was a smoker. Alcohol abuse is very common, but it's poorly identified during pregnancy, so don't be surprised if you learn later that there was a significant exposure and the medical record at the time of delivery didn't really show any evidence of that. Procedures are something that most pediatricians haven't thought about as an issue, but women who have chorionic villus sampling, the prenatal diagnosis procedure, or women who conceive with ICSI, the intracytoplasmic sperm injection, have risks. Fortunately, they're rare, but there are risks related to procedures. So we'll go through some of these. I make a point of emphasizing the fact that being able to prepare for a discussion about an exposure in pregnancy is a rare opportunity. You don't always have that. You're often asked casually by a mother, could it be related to, and then she'll name off something that occurred during pregnancy, and you really won't have a chance. But if you do, there's some guidelines to think about. There's no book to go to that says this is a human teratogen and this is not. So you really need to look at the information available and see whether it rises to the level of fitting that characteristic. I list here several of the characteristics that I look for when I'm reading the literature. Presumably you'll be doing the same. And I'm going to go through each of these to illustrate some issues that you ought to be aware of as you think about, could this exposure have been relevant to this child's problems? First, let's see what's possible. You can see here a long list with examples on the right side. These are all the different kinds of adverse outcomes that can occur from an exposure during pregnancy. Most women are very aware of miscarriage and very concerned that there might have been a recognizable cause. These are not usually well studied because it's very expensive to do that. The funding in this area has never been very good. Pediatrician is more likely to see the growth-restricted child. Be aware of that because in your routine you'll identify those. You're also going to remember from your training that there are patterns of abnormalities that you're taught to look for and examine for. So that's something that would certainly come to mind. And of course, major malformations in general are something the parents are aware of, and they're going to be asking you questions about, could it be due to this, could it be due to that? We'll discuss the fact that cognitive dysfunction or IQ deficits are something parents worry a lot about as related to exposures in pregnancy. These have not been studied as well as we'd like. They're only available for some drugs, but that's an issue to stay attuned to because new data could come out that's relevant to some of your patients. I want to start with showing you some good sources of information. And in my experience in talking to pediatricians and residents in training in particular, they've never heard of these. And it's important for you to be aware that these exist. I really focus on the top two on the list, TERIS, which you see listed here, TERIS, which has been developed by Jan Friedman and Janine Polifka. Janine's at the University of Washington in Seattle, and Jan is in Vancouver at British Columbia. They've developed an information system that you could go to knowing what the exposure was, and it would tell you the quality of the information available, what the risk is. And then likewise ReproTox, which is currently managed by Anthony Ciali. Tony runs ReproTox now and writes the summaries that are in there. Both of these folks do this pretty much because they think it's important to do. It's not something they make money from. These resources are available to me through our hospital library, and I bet they would be available through your hospital library too. You see the micromedics system listed there. If you go into micromedics, you look under reproductive risk information, and it should come up with Terrace, ReproTox, and Shepherd's catalog. So these are really the best databases we've got. They're each updated as often as they can, but they can be right on top of the current information, or they can be out of date. So you have to bear in mind that if you go to Terrace and ReproTox, there could be a time when something that's come out recently is just not there. But they're well-meaning and they're well done. Each begins with a brief summary. So if you're in a big hurry, you can go to them and get in the first opening segment of the entry on a particular drug the critical information you need. Now this is in contrast to the physician's desk reference. I list it here as the worst place to go to get this information. Unfortunately, most medical students and residents are taught that the drug categories A, B, C, D, and X are reliable, but in fact they're not. They haven't been. If you see on these references here, you can see the paper published in 1994. This was a report from the Teratology Society, which is a scientific group concerned about estimating risk from exposures during pregnancy. 20 years ago, they told the FDA that the drug categories A, B, C, D, and X were no good. They should get rid of them. It took the FDA a while to say yes. And you can see in the citation there, a presentation done by Dr. Queter in 2001. She said at the teratology meeting, we realize they're not accurate, we're going to replace them. But the FDA has moved very slowly, and the attempt to substitute narrative summaries instead of ABC is just beginning. The sad truth is that the companies that manufacture these drugs love the PDR and love these categories because it allows them to protect themselves in court. But if you go to specific citations, and I'll list here reference 2 by Lowe and Friedman, if you go to that, you find that the correlation between the drug categories and the information in the literature is just awful. So if you look at that, you see they looked at all the drugs put on the market between 1980 and 2000, and most of them hadn't been studied well enough to know whether they're safe or not. But they compared the quality of the information in the literature as published in Terrace to the categories and found that the kappa statistic, which you see listed here, is terrible. In other words, there are a lot of drugs listed as X that are really not X. There are a lot of drugs listed as D that are really not D. A lot of drugs listed as C, which really shouldn't be listed as C. So probably the most crucial thing I can tell you in this brief summary is, for God's sake, don't use the PDR as a source of information about risks during pregnancy. Now, if you're busy and really don't have time to look for things, this group here, which has a new name, Mother to Baby, is a regional resource all over the United States and Canada. It's also available in Europe under Entis instead of Otis. Otis is a center you can call for information. You could call and say, I've got a patient whose child has XYZ problem and the mother took such and such during pregnancy. Can you tell me about what's known about that exposure in pregnancy? And they could give you information over the phone. They can send you material by surface mail. Likewise, the woman can call. It's a good resource, and I urge everybody to get to know the Otis Center near to them so they can get to know who the people are and how they work. But but it's a valuable resource for the folks that really just don't have time to look things up themselves. Now for today, I put together a list that I thought summarized the kinds of things that if I were a busy pediatrician, I'd want to be updated on. The first two, antidepressants and anticonvulsants, are very common exposures in pregnancy. Over 10% of pregnant women generally take anticonvulsants. Smaller percent, maybe 0.4, 0.5% take anticonvulsants. So let's start with those, because this is clearly where the money is in terms of issues that will come up when you're seeing children in routine care, and in particular if you ask about issues during pregnancy that the mother might be concerned about. There's been a lot of conflicting information about the SSRIs. I would warn you that whatever's written has to be considered one point of view and not necessarily the bottom line. I've listed here on this slide several of the commonly used SSRIs, but the information has been a mess, and it's difficult for you, if you're in a hurry, to sort of keep track of the latest publications and conflicting opinions. SSRIs, as you know, are selective serotonin reuptake inhibitors. Each is very different. So if you look back at this list and you looked up the chemical formula, they're all very different. They're not at all the same thing. Likewise, that means that whatever data we get needs to be drug specific. So yes, they're metabolized in a similar way. Yes, they have a similar half-life, but bottom line, if a woman had an exposure to a specific SSRI, what you really want is data on that drug, not just SSRIs in general. And this slide lists the three major topics that have come up thus far. First is the issue that's gotten a lot of press and also been the subject of advertisements on television in the Boston area, and I suspect where you are as well. Lawyers trying to find families whose child has a heart defect where the mother took a specific SSRI during pregnancy. This issue was first put on the map by the manufacturer, GlaxoSmithKline. They had a website where they're inviting children to be reported who had birth defects after exposures to two different groups. One was bupropion, one of their compounds that they market, and the other were the SSRIs. You can see there fluoxetine, paroxetine, sertraline, and so forth. You can see how this whole controversy got started. They were asking people to report the presence of birth defects, and you can see that they reported a lot of atrial defects and a lot of ventricular septal defects. When I made this slide, I made a point of listing the most crucial outcomes that are listed. You shouldn't expect to see these numbers add up to 36 or to 9. I selected some of the items to show. But the point is, the website highlighted the possibility that atrial septal defects might be more common in this group of children exposed to these drugs. Well, as you know, as a pediatrician, lots of children with heart murmurs have echocardiograms done. Lots of children are found to have patent foramen ovale or muscular VSDs, findings that are often labeled as ASDs or VSDs when in fact they're really not necessarily a birth defect. And so the problem with this original concern, this original red flag that was raised by the company was, are all of these really serious birth defects? Is there a methodology issue that makes it difficult to be sure this is a correct lead? So that led to the need for better studies, and I'm going to show you in the next two slides how difficult this has been to sort out. We start with the first study done by a really large and very well-qualified group. The National Birth Defects Prevention Study is a 9-state collaborative coordinated by the Centers for Disease Control in Atlanta. You can see here that over a 6-year period, they had almost 10,000 children exposed to SSRIs and then 4,000 unexposed controls. And you can see there's some interesting correlations increased frequency of several different kinds of birth defects, craniosynostosis, omphalocele, and heart defects. You can see some of the sample sizes are impressive. 1,900 heart defects, 181 omphaloceles, and over 400 infants with craniosynostosis of one kind or another. Well, when you look at the odds ratios, they're clearly elevated, particularly the first two, 2.5 and 2.8. One, of course, would be normal. You can see that this was published in a high visibility journal, New England Journal of Medicine. You can see that for the first two, craniosynostosis and omphalocele, the 95% confidence interval excludes one, so it's really significant. Barely significant, but still significant. So remember that now before we go to the next slide. So here's craniosynostosis and omphalocele, significant, but heart defects not. Okay, so we go to the next. This is another study by another group published in the same issue of the New England Journal of Medicine. That should be 2007 also. This is a separate research group, an excellent group of people, very high quality interviews of the mothers, high quality information on the presence or absence of birth defects, and look at how different their findings are. The craniosynostosis and omphalocele, which were significant in the previous slide, where the confidence intervals excluded one, here you see they don't. So this big study of almost 10,000 mothers with 115 infants with craniosynostosis, 127 of omphalocele, did not show the significant increase that was noted in the first study. Heart defects were almost significant. So the point is, two large research groups working separately, high quality, came up with very different findings. And I think this illustrates the nature of the information we have on SSRIs now in terms of whether they cause birth defects. I think it's an open research question. So if patients ask me, what do you think about the exposures to SSRIs in pregnancy, I say that the risk for malformations is still an open research question, a lot of conflicting data, it's not settled. They might counter and saying, well, I knew so-and-so went to court and the drug company paid to settle the lawsuit. Well, that's a business decision by the drug company. That's separate from biologic plausibility and scientific data. Tony Sciali, who I mentioned earlier, wrote this nice review. If you have the time and want to read about it, Tony went through the literature on SSRIs and whether or not they cause birth defects and said these are the questions that have not been answered. Is there a dose-response relationship? In other words, the higher the dose the mother takes, the greater the risks to the fetus. You need an animal model for any exposure you think might be teratogenic, so you can ask questions about how it does what it does and look at the high dose compared to the low dose. It ought to make sense. There should be some drug-specific effects. We don't have any of this information yet on SSRIs. So the research hasn't been done well enough to settle whether this exposure causes birth defects. So the women you're dealing with, who are the mothers of the children you're seeing in your practice, could very well have heard all kinds of information from all kinds of sources. I just urge everybody to be very cautious about this. It's just simply not been settled. I can cite you lots of papers that show no evidence of effects, as well as papers that raise the question of whether they cause birth defects. Heart defects have gotten a lot of emphasis, but as I mentioned, there are a lot of methodologic problems with how those heart defects are identified. And it doesn't make sense that a teratogen would cause only atrial or ventricular septal defects. They don't do that usually. Now there's another alleged exposure that I think is valid, and I think pediatricians in my hospital have said, yep, we see that and we really think this is true. This is when the child's mother is on an SSRI late in pregnancy, and when the child is born, there's essentially withdrawal syndrome, where the child has mild symptoms of withdrawal with the irritability that you know about so well, difficulty settling down. This usually lasts only for a short period of time. Supportive care is usually sufficient. It's not considered a major medical problem. And as I said, neonatologists are generally familiar with this and say, yep, we've seen that, and I suspect you will too. Not every child who's exposed to SSRIs shows withdrawal, but many do. And this is a paper that summarized a lot of data that had been collected over the years. So I think it's fair to say this is real. The third issue that's come up about SSRIs is what we used to call persistent fetal circulation, or now persistent pulmonary hypertension of the newborn. You can see here the summary of the information that led to this hypothesis. This was again published in the New England Journal of Medicine. A good group of investigators. They did a very thorough job of identifying in medical records 377 infants that really had persistent pulmonary hypertension in the newborn. That was an important aspect of the quality of this paper. And you can see there's a subset where there was exposure to SSRIs that was significant compared to controls. So, yes, good question to raise, good group raising it, small sample size. This has not been settled, whether this is real or not. And the final point I've already referred to, but I would mention again, once something becomes a subject of litigation, it gets difficult for people to keep straight what the facts are and what the opinions are. As I mentioned, just because something has led to a settlement of a case doesn't mean that there's good medical information supporting that. This is an ad I saw on television in the Boston area many years ago, and unfortunately I've seen it again, so it's not unique to one time. Now, the anticonvulsant drugs. As I mentioned, this is a group that's also fairly commonly used. We found in interviewing a lot of women during pregnancy in the Boston area that about 1 in every 250 had taken an anticonvulsant drug, either to prevent seizures, where the mother had epilepsy, or she used it to treat mood disorders like manic depressive disease or something of that sort. And there's a lot of data that's been collected. But the same general principle here that is you should carry with you when you're thinking about the SSRIs. The risks have to be specific for each drug. You really can't lump them all together and generalize about anticonvulsants as a group. You can see here I've put up the information that summarizes a lot of recent and long-standing work that's been done. There's no question that valproate is the most serious, harmful, teratogenic exposure in this group of drugs. The estimates of the frequency of malformations are varied in different studies, but always quite high. This is data that came from a study that comes from a pregnancy registry for women taking anticonvulsant drugs, something I direct at Mass General. You can see Dr. Hernandez-Diaz is the first author of the paper, published in 2012. In that study, 9.3% of the infants exposed to valproate had major malformations. And the number 2 drug, and again, shown in many studies to be significantly teratogenic, is phenobarbital. Some people are surprised to hear that because phenobar's been around forever. It was put on the market in 1912, and it wasn't until probably 10, 15 years ago that studies began to be done on phenobarb only. And we saw, my goodness, there's a significant risk for malformations. So those two, if you have a patient who is exposed to either valproate or phenobarbital, it's fair to be concerned about both presence of malformations as well as effects on IQ. Valproate has other problems that I'll get to in the subsequent slides, but so those two are really number one on the list of concerns. You see I list as worrisome the data thus far on topiramate-exposed pregnancies. I call it worrisome because the number is high compared to the unexposed comparison group you see listed there. It's a significant increase, but it's a significant increase not only for oral clefts, cleft lip and palate, and cleft palate, but also for other malformations. And when a drug is associated with an increased risk for malformations in general, as well as clefts plus other malformations, that makes us worry that there's something here that's of concern. The sample size of infants whose mothers have enrolled in the pregnancy registry is still only in the 400 or 500 range. That's not enough to settle the level of concern, but it's certainly a concern we have, and other registries have shown the same thing. The good news is some of the new anticonvulsant drugs, levetiracetam, or Keppra is the brand name, is an example of one where the rate of malformations appears to be quite low. And generally, when unexposed comparison groups reach a sample size that's big enough, they show a range of about 2% as the frequency of birth defects in an unexposed control group. It happens in this particular control group, it's down as low as 1.1%, but in general, 2% is probably a fair comparison. And you can see 2.4% in the levetiracetam exposed compared to 2% really wouldn't be a significant difference. You know carbamazepine and phenytoin, long-standing drugs. It's pretty clear their effect is only a modest increase, and you can see them listed there. Now, everybody should be worried about specific malformations produced by specific drugs, and this shows you the ones that we know about at this time. Again, it comes from this paper published in Neurology in 2012. Myelomeningocele, spina bifida, it's clearly increased in children whose mothers took either valproate or carbamazepine. What's been amazing in this pregnancy registry is to find 6 drugs associated with a significant increase in the risk for either cleft lip or cleft palate. And that was a surprise. Everyone knew from the old literature that it was true for Phenytoin, brand name Dilantin, but it's amazing to see how many drugs are on that list. And this seems to be real. We need more data to be sure, particularly for the new drugs like lamotrigine and topiramate. But for the old drugs, it's pretty well established. We also need more information before we can decide whether any of them has just cleft palate only as an effect, as opposed to cleft lip and palate. I've already mentioned the issue about some drugs are associated with an increased risk for multiple birth defects. That's definitely true for valproate. The children whose mothers have enrolled in our pregnancy registry, which is the North American AED pregnancy registry, have multiple malformations of several organ systems. The data on topiramate-exposed children is still limited. The pattern of abnormalities is not as dramatic and severe as those in the valproate-exposed group. But as I said, we're worried about it and need more information to settle whether that concern is justified or not. I thought I would note the part about these exposures that's less well sorted out. Mothers are going to be just as concerned about how well the child does in first grade and in school in general as she is malformations. She will, as you know, she's already examined her baby at birth and could convince herself the baby looked okay and has settled the malformation issue before you even see the child. The issue that can't be settled without really well-designed studies is, does this child have problems in learning? Does this child have a lower IQ than an unexposed comparison child has? And unfortunately, that literature is much more limited. So if you're dealing with a woman who's concerned about school performance and exposure to an anticonvulsant drug, or a SSRI for that matter, don't be surprised if there's really not good information. These studies take a lot of time and funds, and they have not been as available as we'd like in this era to study these drugs. But the data available clearly shows that valproate is associated with a significant decrease in IQ as well as phenobarb. And also, there's pretty good evidence that the child exposed to valproate has a much greater risk for problems like autism. We get a lot of phone calls from women asking about whether their child's autism could be related when the mother took other drugs like levetiracetam, lamotrigine, carbamazepine, whatever. The systematic studies just haven't been done to settle whether or not other anticonvulsant drugs are associated with increased risk for autism. That's something that is currently being looked at, and hopefully we'll have more information in the future to settle that issue. Obviously, when a child has autism, parents are really eager to find a cause, and you probably have them seen by a geneticist who will do chromosome microarray and other things looking for various associated cause factors for autism. Well, this would be another group. Hopefully the literature will flesh out more and we'll have more answers on other drugs. Now I list one thing here that's might be a surprise to you. Most pediatricians don't think of exposures to anticonvulsant drugs being associated with an increased risk for growth effects. But you see here some dramatic findings, again from our pregnancy registry. Again, Dr. Hernandez-Diaz was the first author. She's a very senior epidemiologist working at the Harvard School of Public Health, where she's a professor. You can see the data as was analyzed showed among the controls about a 5% frequency of infants having a birth weight below 10th percentile. And by comparison, topiramate and zonisamide exposed infants had a much higher risk for being growth retarded. These children often seem to catch up. We can't find literature that actually documents that yet. No one has published a study of topiramate-exposed pregnancies where they show growth restriction at birth, and then by age, whatever, 3, 4, 5, that they've caught up. We're more concerned about the potential long-term risks in SGA babies. This is something that hasn't gotten a lot of attention among pediatricians, and it tends to project to just the teenage and then the adult years as an issue. So I'd keep an open mind about this and hope that literature begins to be available on children exposed to either topiramate or zonisamide during pregnancy in terms of how well they do as adults with regard to obesity as also high blood pressure. But clearly being SGA is not a trivial finding. The manufacturers of these drugs are having to decide whether or not to include this as part of the package insert to alert the mothers to this as a risk. And I don't know how that's going to turn out, but we know it's a definite risk, and other studies have shown the same thing, so I think it's real. But we still don't know the long-term significance of a baby being SGA after either of these exposures. So here's my summary, putting this together. For reasons we don't know, the old anticonvulsants, methamphetamine, phenobarbital, valproate, carbamazepine, have greater fetal risks to the fetus than the new ones. We hope this is somehow related to the way the drugs are developed in terms of their structural formula, their metabolism, some aspect of that that's the basis for this apparent improvement in the risk. As I mentioned, that's true in general for topiramate, for levetiracetam, lamotrigine, but we are concerned about topiramate, which would fit into the new anticonvulsant group, and it is a cause for concern. As I've mentioned a couple of times, but I think it bears repeating, there's just not been published systematic data on all of these outcomes that pediatricians are naturally going to want to find. You don't have good, extensive studies on any of these exposures except for valproate to show whether there is an increased risk for autism or not. And I've already mentioned the increased risk for being SGA. If you're looking for data on IQ, it's not only hard to find it, but you really have to have a pretty high standard if you're going to use that in counseling families. And we'll talk about that more in a moment. But the gist of it is, it needs to be a well-designed study. The children should be 6.5 or older. There should be a sex and age-matched control. Parents should be evaluated. You need to be sure the mother and father of the exposed child is similar to the IQ and occupation and education level of the parents in the control group. And that's difficult to come by. Okay, so we're moving on now from the two common exposures, the antidepressants and the anticonvulsants, to some less common exposures that have more dramatic effects. And these are mainly to illustrate some points that the pediatrician needs to keep in mind as you see children. And the point being made by accutane here is, I'm sure you've already heard, it's really a terribly teratogenic exposure, but it emphasizes a key issue for you. You can see here summarized in this slide, accutane taken by mouth, 35% rate of malformations. I mean, that's an enormous risk compared to 2% in the general population. And among the children who aren't malformed, there's a very high rate of mental retardation as well. So really dramatic and serious teratogen. The point of the slide is compare that to retin A. As you know, it's applied topically. But the gist of it is, while the compound in retin A is metabolized to the same compound that accutane becomes, all-trans retinoic acid, retin A is not teratogenic. It's just simply not that well absorbed. And so the blood level in the fetus just doesn't get to the level that would be harmful to the fetus. So the point being made is same compound, one taken by mouth, one applied on the skin of the mother, very different risks. Now this illustrates also the fact that the PDR doesn't give you good advice. The PDR typically warns, I don't know which issue you have handy, but the ones I've looked at typically say retin A is contraindicated during pregnancy, and there's just no evidence to support that. But that's reflects the reason the companies use the PDR as a way to protect themselves in court. They can say, we advise you not to use it. So here is the documentation of the high risks from accutane exposure. This unfortunate little boy was exposed. You can see he's got the cranial nerve palsy. You'll recognize there where the left side of his face is showing the normal response to smiling and the right side's not smiling, and that's because of the cranial nerve palsy. You can see the closure of his eyes is different on each side, and you can also see this dramatic ear deformity. Very unusual kinds of ear deformities are produced by accutane, different from what you'd ever see clinically in an unexposed child. And here's just a close-up view. So accutane is probably number one in terms of the dramatic high risk for malformations and high risk for IQ effects. It's still being used inadvertently during pregnancy. Sadly, all the efforts to get it off the market, except in well-controlled circumstances, have improved or decreased the frequency of accutane-exposed pregnancies, but they're still occurring. So if a mother gives a history of having used accutane, that's should be a source of great concern. Obviously, you'd want to look for any structural abnormalities, but also be concerned about that child's development. Now this slide concerns exposure, in my experience, most pediatricians haven't heard about. And it really is a pretty uncommon situation. You're talking about drug exposure for a woman who's had a transplant. Kidney transplant would be the most likely situation. Mycophenolate mofetil has been very good in helping prevent the rejection of kidney transplants. It's also been used frequently in treating lupus nephritis. And unfortunately, the various transplant registries stumbled in a few years ago to the fact that, oh boy, these children really seem to be have an increased risk for a lot of different anomalies. You can see here, I've listed the ones that have come out in the published articles, various abnormalities of the eyes, really severe development of the ear, microtia, very small development of ears, the clefts, esophageal atresia, heart defects, a wide pattern. They all don't have all of these, but it's a serious major risk. The actual magnitude of the risk is still not known. Like any of these exposures, including accutane, there's going to be children whose mothers took an amount of concern and the child appears to be okay. So it's not 100%, almost no exposure is 100% in terms of fetal damage. but as I mentioned, the actual magnitude of the risk is just unknown at this point. This is a collection of slides from different publications. You can see that the medical literature exploded with reports on these children in the last half of the first decade in this century. You can see 2008, 2007, lots of reports. Fetuses were being diagnosed during pregnancy once this exposure was shown to be so teratogenic, and the pregnancies were terminated. Children were born with what appeared to be clefts, but when the pediatricians did the exam, they found facial abnormalities as well as clefts, as well as microtia. And so it's pretty clear that this is a high-frequency event, but the exact magnitude of the risk has not been settled. So if you're dealing with women who've had a transplant, this would be the kind of issue you really need to think about and learn more about the exposure that child had. The third in this group of slides that's not common but of concern is Coumadin or warfarin. You know this is an anticoagulant, been around a long time, and it's been 30 years since the teratogenic effect was first noted. So this is not new information. This has been around a long time. It doesn't get talked about very much. But these children come through the system, and the mother doesn't always realize that her taking warfarin because of a heart valve or deep vein thrombosis or something like that posed a risk. Not all physicians caring for people with those problems are aware of this risk. Well, let me show you a couple of examples. Now here's a dramatic example. Here's a little baby at birth, had dramatic underdevelopment of nose cartilage. You can see there's just nothing to be seen on the lateral view. The frontal view, it's quite short. This is, if you ask a geneticist who's attuned to rare abnormalities and what they might be related to, if you show them some child with dramatic nose hypoplasia, they should come up with Coumadin or warfarin exposure as a good possibility to think about. Here's an infant we saw in our work at the old Boston Lying In several years ago. You can see this child's nose hypoplasia is not as dramatic. This is more typical of what the warfarin effect is. This child did well, and the nose hypoplasia was simply a cosmetic issue. If you remember the slides I just showed you, there are other subtle effects. There's shortening of the distal phalanges in the fingers, not the toes, and there's stippled epiphyses that you can see if you do a radiograph. These go away over time, but at birth they should be there. So if you're seeing a mother, the infant of a mother who reports having used Coumadin or warfarin during pregnancy, this is a good thing to know about. It appears that the Coumadin really damages cartilage formation. It's not produced by hemorrhage in the fetus, as everyone assumed must be the case. The good news is that if she can get off the medication before 6 weeks after fertilization, the child could easily escape this. And the magnitude of the risk appears to be in the 2 to 3 to 4% range. It's not as dramatic or as high as either accutane or the mycophenolate. ACE inhibitors. Most people in their training have heard at some point about the concern about ACE inhibitors that the mother takes because of high blood pressure, renal problems of one kind or another. And it was pretty well worked out 20 years ago that the problem is the woman who's taking ACE inhibitors in the second and third trimester of pregnancies develops severe hypotension in the fetus, and that this is really what causes the poor kidney development and the lack of normal amount of amniotic fluid and the developmental problems that can often be lethal to the exposed fetus. So the word spread pretty quickly that, gee, this is a serious exposure. We don't know the actual risk for an ACE inhibitor exposed pregnancy, but it's certainly increased. And everyone was relieved to know that, gee, if you get her off in the first trimester, you're out of the woods. So that was where things were 20 years ago, 10 years ago. Then this paper comes along, which messes things up. So as a pediatrician, if you are seeing a woman whose child was exposed to ACE inhibitors during pregnancy, and you do a literature search, you're going to quickly come across this paper. Cooper et al. They published, again, in the New England Journal of Medicine, a dramatic reversal of the information that had been previously taught. They showed, in going through the Tennessee Medicaid data set, that there were a lot of children who were malformed whose mothers had exposure to ACE inhibitors in the first trimester. You can see here there were 18 malformed out of 209 exposures in the first trimester. 7% frequency, relative risk of 2.7, in other words, 2.7 times higher than the general population risk. And they had an unexposed group, which was huge, 29,000, and you can see the rate of malformations is much less. That didn't make sense. So if you remember that list of principles of characteristics of something that's an exposure, it should make sense biologically. So if you look here, the thinking had been it's a second and third trimester effect. How come this paper comes out in the New England Journal saying, nope, first trimester is teratogenic? Well, it didn't make sense biologically. And when you looked at the Tennessee Medicaid data that was being analyzed and published, there was no specific pattern of abnormalities that you could hang your hat on. So everyone was in the teratology world was suspicious that this was a study design problem. It wasn't the drug. And you can see two groups went at it. Janine Polifka, I mentioned her name earlier. She's one of the people who run Terrace. She and Jan Friedman. She wrote a critical review that was published in Birth Defects Research. She published it in 2012, came to the conclusion that this didn't make any sense biologically that Cooper had shown. And a group from Israel, shown here, published in Reproductive Toxicology, essentially showed the same thing. They had an exposed group with a frequency of malformations of 4%, an unexposed group was essentially the same. So it took some time to show that this New England Journal paper simply was not correct. So if you're dealing with people who've been exposed to ACE inhibitors, don't be surprised if they're aware of these conflicting reports. I think it was nice to see that the principles turned out to carry the day, and the principle is it should make sense biologically if you're going to allege that a first trimester exposure is teratogenic. And ACE inhibitors don't fit that. Misoprostol. In my experience, pediatricians have usually heard of 1 or 2 exposed pregnancies during their residency. We see them at Mass General maybe a couple every year. And these are typically women, not native-born Americans, but people from Central American countries, Dominican Republic, where in their culture and in their country, women who've not had their menstrual period, concerned they might be pregnant, have learned over the years, if you're not sure you're okay and you want to be sure you're not pregnant, there's this pill you can take. And they usually don't know what the pill is, but the mechanism of action is shown here. Misoprostol is marketed by a U.S. manufacturer as a drug taken to prevent the abdominal pain from an adult using a non-steroidal anti-inflammatory drug. It was noted in the package insert that it produces endometrial bleeding. Women picked up on that and began in those countries to use it frequently for an elective termination of pregnancy. And you can see the mechanism of action is spelled out here. It produces intense uterine contractions. Women describe how painful they are. They usually last for 2 or 3 days. And the armchair reasoning about how it damages the fetus is shown here on this slide. Decreases blood flow, hypovolemia, endothelial cell injury, hemorrhage, tissue loss. So you get, in these children, what looks like amniotic band type deformity. You also get other things, cranial nerve palsies, arthrogryposis, a variety of effects. And it appears that the frequency is a 2 or 3-fold increase over the background rate in the general population. So a woman might have a child with either cranial nerve palsies or arthrogryposis. She might be totally unaware of the fact that the pills she took trying to terminate the pregnancy could actually have done this. In my experience, so often the women take the medication, they don't really know what it is, they get nervous about the effects that it's having on them, the bleeding, they have ultrasound done, shows the pregnancy is continuing, she feels very guilty, wants to continue the pregnancy, then you're sort of left with the difficulty of knowing quite what to do. The child at birth should be examined carefully for this list of possibilities. The good news is the child can be okay, but there is an increased risk for some abnormalities listed there. They're generally the vascular disruption kind of birth defects. Unfortunately, in Central America, Dominican Republic, Brazil, a lot of South American and Central American countries, abortion is illegal, so this is part of the options that are very popular. And so pediatricians who take care of a population where this is in use, where this could be in use, need to be sensitive to this correlation. We had one contact by a genetic counselor in New Jersey who described how the 21-year-old who'd used this in her unwanted pregnancy had gotten the misoprostol from a Dominican grocery store in New Jersey. So I think that sort of illustrates to you that it's around on the black market, and obviously in New Jersey it was there in a Dominican grocery store. So they can often find it, but just to repeat what I've said a couple of times, the women usually don't know this is what they took. They just know their friends told them, if you want to stop the pregnancy, this is one way to do it, and it doesn't always work. Our obstetrician friends tell us that misoprostol is used for terminations of pregnancy along with methotrexate. That's a standard way of terminating pregnancy. They just use a higher dose, and that's why these women typically, so many of them have the pregnancy continue. There's some false alarms I wanted to bring to your attention. Many people have been taught in training that lithium produced particular problems in the right side of the heart, the Epstein anomaly. This came from a post-natal registry. It was biased. It emphasized these abnormal outcomes because women were invited to report findings in their babies after they'd been born. It's a rare outcome. It'd be impossible to prove because it's so rare and be very difficult to find enough cases to ask the question. Here's one such study that was done where they had 148 women who used lithium in the first trimester and a comparison group of the same size, and you can see the frequency of malformations was the same. You also see in the footnote that one infant in the lithium-exposed group did have the Epstein's anomaly. Lots of people have seen one case here, one case there. The problem is it's very difficult to prove it. This right here is the key comparison. There appears to be a small increase in the risk for heart defects in general in lithium-exposed children, but it's more in the range of a 2-fold increase. And the Epstein's anomaly is a possibility, but it just hasn't been settled in rigorous, well-designed studies. Concerns have been raised about lithium with regard to other outcomes. I list this as an example of what you could find in the literature if you were searching. Just because it's been published doesn't mean it's true. This is what this author found. So if a woman delivers a baby and she was on lithium, this is something to bear in mind. And if you think it's of concern, then you or someone to whom you refer the child should explore whether or not there's anything to the correlation that the woman's presenting. Phenytoin, or brand name Dilantin. Most pediatricians were taught, based on data from the 1970s, that phenytoin-exposed child has an increased risk for birth defects and also for our mental retardation. This shows the findings in a careful study that we conducted, haven't published yet. 40 exposed children where the child who was exposed was carefully matched to an unexposed child. The parents were similar IQs and occupations and education. When you did it that way and examined the children over age 6, there's simply no evidence of an IQ deficit. So it's sort of in the category of things you were taught based on early information. This was from the late David Smith, who was a revered clinical investigator. Whatever David said, everyone assumed was true. But this is an example where you're focusing just on Phenytoin exposed alone. Dave, in his studies in the 70s, had children who were exposed to phenobarb and Phenytoin. And phenobarb unequivocally causes IQ deficits. So Phenytoin was blamed unfairly for causing IQ deficits, and I'm not sure that's true. The exposure should make sense. We've already talked about this as characteristic for the SSRI drugs. Is there biologic plausibility for their causing heart defects and so forth? That data hasn't been provided yet. Those of you watching this tape that are old enough will remember from the 80s that 10–20% of pregnant women were taking Bendectin. And so there was a time when there was this flurry of concern and a flurry of litigation suggesting that, gee, in 1960, thalidomide caused birth defects. Now here in 1980, Bendectin is doing that. Well, the data was never there. The Canadians, to their credit, looked at the data and put Bendectin back on the market, although it was kept off the market in the States because the litigation costs made it uneconomic for the company to continue to market it. And you can see the drug company in Canada that put it back on the market there has just reintroduced it into the United States. It's been on for about a year. And this is just another New England Journal paper announcing that's back on the market here. So here's an example of an exposure that led to an enormous amount of litigation, but simply didn't make sense as a teratogen. And the subsequent studies showed that was the case. And now it's back on the market in the States. And we'll see whether or not the flurry of litigation returns with it. Breastfeeding, I want to put these resources in this tape because you get a lot of questions about breastfeeding, I'm sure, from your patients. There's some general rules of thumb that I always tell people. There's only limited indications. If the woman is taking a drug that produces sleepiness in her infant, you really want to monitor that infant carefully for weight gain. And if the child seems too sleepy, that would be the reason to say, you know, she needs to either change her dose or decide not to breastfeed. There are a couple of specific indications for not breastfeeding, and they're shown here. Now, just some general comments in closing. When women raise a question about exposures in pregnancy and whether they could be an issue in the child's problems that you're evaluating, I urge people to be very thorough about this. It really helps if she sees you be thorough in your approach to it, not just giving her off the top of your head comments. Be careful about where you go. I've already told you about Terrace and Reprotox as sources. Don't rely on the FDA's drug categories. Have a decent discussion. Allow some time so you can really go over what you've learned in reading about it and have some ideas about where you could refer her if indeed she wants to discuss it with someone who has more experience. If you're going to hand her something written, be careful about that. Make sure it's valid, that it's accurate. There's nothing wrong with handing her the report from Terrace or Reprotox if you feel it's up to date. But it is the sort of situation where you need to be thorough about it and show her you've really spent time on it, because that will be what will convince her that she's raised the question and has gotten a thoughtful answer. The information is out there, but unfortunately you have to spend some time to pull it together. But good luck. This is a